A lot of people have tried to, not get away, but move away or supplement the old surgical approach to teaching, see one, do one, and yeah, I think a lot of things have failed. Some of the virtual stuff and the sim alone is limited, but this seems to have legs and seems to really be taking off. What are the people who do it? What has come out of it? What have people said, and what do the
Yeah.
data show?
So again, we're a research, entity, and therefore we collect data. And our main objective is we're trying to get to is that, when a pilot learns how to fly a plane, they do a majority of 100% of their learning in a very sophisticated VR simulation. Now, for them, that is very realistic because all they need is the buttons, the movement, and also, the scene that they're looking at. And so the pilot doesn't get dissociated thinking that this is pretend, this is real life. And so the first time that a trainee pilot is flying on a plane, yes, with their co-pilot being an experienced pilot, is where 300 passengers are on the plane. And so that's called zero flight time training. Now, for us, unfortunately, none of our patients come with their own operating manuals telling us, where the different buttons are. And at the same time, we're considered a very high risk, kind of entity. Yes, it's one patient, but this is very high risk because there's a treatment. It's not just getting to a final destination. And
Right.
so from our standpoint, we have to make sure that we have a competent surgeon prior to them operating. And so my goal is that we reach a time where anybody that's going into the operating room has actually done a robust curriculum that allows them to start training in the operating room by refining an approach. So imagine a resident that is training at the level of a fellow,
Right.
right? You've done significant training where you are. Now you're going to refine your approach. I want that to happen during residency because we have the capacity to do that. We're not the only discipline that's been doing this, right? Orthopedics does it, anesthesia does it, plastics has also been doing it in different countries. Urology has yet to do that. And there are, of course, a lot of resource issues, there's money, there's a lot of barriers to this, but I don't think it's something that we cannot set standards for and tell and pave the way that everybody can use this. My goal is to not corner this field and say our models are the best and nobody can replicate them. We're actually very interested in partnering with a lot of other institutions and supplying these for them until they learn how to do it. So in our single port curriculum that is endorsed by the Endourology Society, we are sending to 10 fellows all these models for free for them to practice on them. The online platform, they have full access to them. The training platforms so we have a meeting in September, the SIRS meeting, where we have the fellows come in and actually do their proctoring on the full models. And so we've provided this almost free of charge. Yes, we've applied for societal funding. We've applied for industry funding, which we've been lucky to have some of. But our goal is not to sell these or commercialize these or utilize them in any way to corner the field. Our goal is really be able to replicate this everywhere. We're actually working on a very, this is pretty confidential, but we're working on something that allows anybody to make these models using a certain machine. And our hope is that once you get this, you will be able to recreate these model right at your own institution because it takes a lot of effort and a lot of training and a lot of infrastructure. Our annual lab kind of expenses range
Yeah.
between $300,000 to $400,000, and that's not something that any institution can burden. Again, we have a significant amount of grants that we strive to get to lessen that, but still, that is a significant burden that
For sure.
we don't expect every institution to do this. We do expect some of the eminent institutions to be able to replicate this and then be able to spread it out to other institutions and other entities as we wish. And again, we're hoping to partner with, societies, the American Board of Urology, a way that, can be an entity that can then supply these models to all the rest of the programs.
Yeah, it is unbelievable and really unbelievable what you're doing, and that it's becoming so much more regular over time. To use it just indicates, your success in getting this implemented. What was I have only a couple more minutes, but what was the give me a time where you're like, maybe I'll just give up on this and
Yeah.
have to get through it.
There were too many of them. All right. I have to say there were too many of them. Look, this is what I learned in that Dean's Teaching Fellowship. And there's a book by Cotter, who was actually a business professor at Harvard. It's called Our Iceberg is Melting. And it talks about, you know, a fictional penguin colony where their iceberg has a crack in it, and how to get through change. It talks about change, how you can instill change in leadership and the people around you. And I've learned a lot of that from that book. And the idea behind that is really you have to create a status quo, and you have to take those little wins. So, you know, my first min was winning really the best video at the AUA at the time, where they used to take all the videos submitted to the AUA and choose the best three. And we were the best video. That was the first time I submitted a video of my simulation. And that for me was a big win. And every once in a while, we get these little wins, you know, even you praising our models and seeing people using them and being very happy with them and being very satisfied. My residents today, I had a sim session with this, and they were like, this is awesome. That is, to me, the passion and that keeps the fire going. And, you know, I want to really be able to say that we had a big role in training a significant population within the US of urologists, and be able to say that our models are becoming the standard of training, not because we're the only ones that make them, but because they're available, they are truly realistic. And it's things like that where you then feel, right, that, you know, you can't give up, because you're giving up on a big dream and a big goal. My biggest really hindrance and my biggest barrier is the ability, because different institutions have different kind of way, you know, they want to always protect their technology, and it's really being able to widespread these models. And we've been given the luxury of being able to provide a significant number of these models, you know, free of charge, and have a lot of people who utilize them. But again, I want to set a standard where everybody does this. And our first movement towards that is really developing a training center here at Hopkins, where people can come and use these models and be able to train from experts, not only from Hopkins, but from other institutions, and developing a very regular training program. This is a way to incentivize other programs to say, well, I also want to develop a training program. Can I use your roadmap? I was like, this is the whole blueprint. You just need to follow this, and let's team up, collect the data, and be able to really congregate a significant data set where we're able to say that what we're doing is truly beneficial for patient care.
I think we're gonna get there, and I think that, you know, this is I think we're in the beginning of this, you know, which is kind of cool to interview at this point in time where it's well known, it's getting there, but there's so much. I usually ask now, like, you know, where do you see us in 15 years? But I don't even know, you know, the sky's the limit, and the need is great.